naprawdę bardzo się cieszymy. Nie mogła z nami być na jubileuszy, bo coś tam wysłali w dalekie kraje, żeby być zamkniona, ale przynajmniej teraz Singapur, no właśnie. Chwała Bogu, że teraz jest i bez koronawirusa możemy się cieszyć wisią i się dowiedzieć coś o Respiratory, Chronic Obstructive Pulmonary Disease. Więc bardzo serdecznie witajcie Wisiu i zapraszam. The rest is in English, so easier for you to know.
Bożena, bardzo dziękuję za zaproszenie na wykład. Ja muszę przeprosić Was wszystkich, że będę mówiła po angielsku. Ja mogę powiedzieć wykład po polsku, ja potrzebuję przesłuchać, przetłumaczyć. Naprawdę nie było czasu przetłumaczyć przez oczy, więc ja będę mówiła o chronic obstructive pulmonary disease, o chorobie Osztera. Okay, so this is a pathological specimen of somebody with emphysema. So COPD, chronic obstructive pulmonary disease, is a progressive disorder that affects the airways, starts in the small airways, and then leads to the development of emphysema. So by COPD, this is a healthy airway bronchial alveolus in COPD. And I apologize for those of you who are very familiar with the condition. I thought we'd get everybody up to speed. There's destruction of the alveolus excess mucus, and you get narrowing of the bronchiole. So you get smooth muscle hypertrophy, and particularly you get chronic bronchitis. So the old terminology of this disease was chronic bronchitis and emphysema. Chronic obstructive pulmonary disease was an American term that was accepted all over the world. I'm actually going to share with you some historical aspects today. I think it's very interesting how thinking about the disease developed. So there's a lot of inflammation, so we use anti-inflammatory drugs. One of the problems we have with COPD, as opposed to asthma, is that it is much more difficult to treat COPD with anti-inflammatories. Some people respond, some don't, and I'll talk to you later that, for instance, we haven't really done well with biologics in COPD. So this is a progressive airway disease. I am going to show you this curve a few times, because I'm going to talk about global issues, then I'm going to talk a bit about my interest with it, which is exacerbations of COPD, and some of you know that I have spent 20 years measuring viruses in airways, and I can tell you straight off, it's not as easy as you think to measure viruses in airways. But this is the old version of COPD, this progressive. If you've never smoked, this is lung function over age. At the end, my last few slides are going to show you this isn't actually quite right, but let's keep this at the moment. If you smoke, you lose lung function much more quickly. If you stop, and this was a dotted line, Fletcher and Peter never actually looked at smoking cessation, but they hypothesized, and this is why I've got hypothesized, that you would get better. In fact, if you stop smoking with COPD, you can still get progressive disease. The commonest cause of smoking of COPD is smoking, occupational factors, pollution, and biomass. And I'm going to talk about some of them in a moment. So I'm sorry about this. I've tried to put a line in. This is some data about how common, this is Lancet Respiratory Medicine, is COPD and asthma. And this is the key line global. So basically, in the world, there are 3.2 million deaths a year. It's around 20 to 30,000 directly attributable to COPD per year. Of course, there's also deaths from pneumonia, which are very high, and a lot of pneumonia deaths are in COPD patients. But basically, COPD deaths are increasing. Now, around how many people have COPD in the world? 175 million is the estimated numbers, but it's probably double. That's where you know that people have a diagnosis. If you look at asthma, there's double the number of asthma cases, 358 million, but but asthma deaths are an eighth. They're 397,000. So asthma is much less likely to cause death. It's much better treated, easily treated, while COPD is a progressive disease mainly of the elderly. And this is why you see so many deaths. And 90% of these cases are actually in lower to middle income countries, and this is very important. So this shows you disability years, and it shows you where the burden of this disease is. To be honest, I don't believe Russia at all. I think it's much greater. Remember, this data depends where it's been collected, but you can see the hot spots basically in Africa. So as we are reducing less smoking in the northern hemispheres, we are seeing much more. We're seeing COPD congregated in these countries. So this was the bold study. This was published about 7 or 8 years ago, and what these investigators did, they went around certain towns, and you can see Krakow is here, and particularly where they were interested investigators, and actually measured lung function. They measured spirometry on people. And you can see hotspots, Cape Town, this is Lexington, which is a fairly sort of middle America place. You can see in Krakow, in women it's 10%. Krakow is higher in men at about 15% of the population. So these are population-based prevalence studies, and that is a lot. And that reflects the large amount of smoking that we certainly used to see in Poland. I assume it's coming down now. But this was interesting. In the UK, we are probably, COPD is probably at around 5 to 10%, but we have around 2 million COPD cases. So what we know about is between 3 to 5%. So why do we have such a problem in Africa? And this is biomass, so this is in fact cooking, and you can see this young child is actually exposed to fumes from the cooking oil. And as I'm going to show you towards the end, we now believe that what happens in childhood affects lung function downstream. In fact, it may be even earlier than that. If you have low lung function as a child, you can catch up. If you smoke or have continual exposure, you will not catch up. And this shows you what happens in schools from fires burning. And I think this was actually in Malawi. So Steve Gordon runs a very large Wellcome Institute in Malawi, where they've done a lot of work. So what about household air pollution and mortality? And you can see where this is congregated, where we expect China, India, particularly Africa, and actually even parts of South America. So this is one of the reasons that we have such a problem with COPD around the world. So what can we do about it? So what they've done in Malawi, they've improved cook stoves. These are some of the new gadgets they've done, monitoring carboxyhemoglobin levels. It's actually very difficult to prove improved outcomes, though there are now papers coming out that if you really tackle this, you certainly improve outcomes in children with less infections. If you have less infections as a child, you're less likely to have problems with your lung function. So the other thing that was interesting, this was a very recent paper I came across, and it's always said there's a lot of COPD at high altitude, and people thought, well, maybe the air, though, that wasn't a good exception. But this is interesting. So this is in Kyrgyzstan. And what these investigators found is that at high levels, you see more basically PM2.5s, and you see more pollution. And they map this very nicely. This is female, males, so this is the highlands, this is the COPD prevalence, and these are the household air pollution exposures, HAP, and you can see how that maps on to the increase prevalence of COPD in highlands. And I think the same probably applies in Peru, because if you remember, there was an increased chance of having COPD in these countries. So this is interesting. There's a lot of factors working on this. Environmental, also occupational factors are very important. I spent about 5 years going up and down to Newcastle investigating the welders when the shipyards were being closed in the UK. The government knew that there was a lot of lung disease among the shipyard workers. So I was then a recently appointed consultant, was asked to be the sidekick to somebody else who in fact investigated this. And this was very interesting and actually led to my interest in this condition. So certainly these people worked in the ships all the way up the northeast in very confined quarters. These were welders, burners, and also they had, of course, quite a bit of asbestos as well. So we spent 5 years, every third Saturday we used to go up to Newcastle and see loads of these people and assess their degree of disability. Okay, so let's do a bit of history. So these are the smog epidemics of 52, 54. This is the one in Ibus. It goes up Streatham High Road, those of you who know South London. And this is the conductor with a flare leading the bus. On the right-hand side, and those of you who are Arsenal supporters will tell me who that is, that's Highbury, that's the goalkeeper. So the last time I haven't shown this for a bit, somebody put their hand up and told me exactly who it was, but it was the current, a very famous goalkeeper, and the match was abandoned. So this is what was going on in 52, 54. We had a very high prevalence in this country of bronchitis. Just fast forward to 2019, this is data from our group. We run the cohorts of patients, we've followed patients for over 25 years now, and these are mainly London-based, but what we did, we looked at the contribution of oxides of nitrogen. You can look at other pollutants. So this is where you don't have an infective exacerbation. There you do have an infective exacerbation. This isn't the best way to look at this, but we looked at lengths of exacerbations, and you're more likely to end up in hospital during pollution episodes, and that is because viruses interact. So this on the left is where there are low nitrogen oxide levels in the air. Here there are high, and you can see that these exacerbations here are much longer. So these are 0, 20, 40. The curves have shifted in the right direction. It's very difficult to know how to show these pollution things, always very difficult to show. What we showed is, when we analysed it further, that it was the virus-related exacerbations at the time of high NO levels in the air that caused longer exacerbations. It took about 3,000 COPD exacerbations and 20 years of follow-up to actually show this. So there is an effect on pollution on exacerbations. It's particularly strong in China, in Hong Kong, where a lot of work's come out on this. In the UK, it's there, but it's not such a strong signal. But the signal acts together, particularly when you have a more severe exacerbation associated with virus. So we had the smogs, and there was already a lot of interest going back to 1944 at Barts, and really the UK led the way on this disease. In 1961, chronic bronchitis, a 5-year follow-up. So there was increasing interest in the whole concept of bronchitis, and then definition and classifications. In 1965, the Medical Research Council convened a meeting to come up with diagnostic classification. And in fact, the definitions of chronic bronchitis are still used for chronic bronchitis, but the Americans, as I said, persuaded everybody to use this awful term, chronic obstructive pulmonary disease, which I think has confused everybody. And this led to, again, to Fletcher and Peter coming up with their work, who define the progression of the disease. Now, this is what they came up with. What they actually said was that bronchitis was not important. And this was actually wrong. And why did they get it wrong? They got it wrong because they did actually a cross-sectional study and extrapolated. But this was very important because back in the 80s, when I was a junior doctor, I was doing clinics, and I was told, well, don't worry about people getting exacerbations of bronchitis, don't give them antibiotics, it doesn't matter. Well, actually it does matter. We now know that bronchitis is probably the earliest sign that you're going to get into trouble. They also said that exacerbations of COPD do not lead to decline in lung function, which was actually wrong. So that was the thinking behind this for very many years. What we do know that if you stop smoking, lung function can improve. So this is data from a very large study done in the US. It was called the Lung Health Study. As you can see, these were mild patients, and the patients who quit, about 20% quit in the study. There was a lot of impetus for them to quit. The continuing smokers showed further decline in lung function. So before we do everything, smoking cessation is very important in managing this disease. So the disease develops. These are what we call, and some of the more recent things we can do with imaging. Inspiratory, expiratory CT. So if you do an inspiratory CT and an expiratory and do some interesting work on the computer, you come up with yellow are small airways, the red is emphysema. So this is mild, moderate, severe, very severe. And what you can see on these pictures is that the disease starts in the airway. So bronchitis is very important. It's very early. Indeed, you lose more lung function at this stage if you get an infection than you do down here. So it is really important that we look out for people in primary care who are getting winter bronchitis, because these are the people who will get into trouble. And I will come back to this at the end. Emphysema you can see mainly once you get into gold 3 and 4, so that's severe, very severe, that's when the emphysema. We used to study, so if you're a hospital physician, you see people mainly down here. This is where we need to tackle the disease, and we also need to tackle this disease much younger. Our average patient, so Sarah, how old are our patients we see in the clinic? 60 plus?
Yeah,
these
late 60s.
Late 60s. We're seeing people later. The problem is these people have had the disease for 30 years, we just don't know about it. So my last slides are to show you some of the work we're doing about early detection. So what about UK statistics? 3 million estimated UK, as I said, 1 million, I think it may be 2 million now diagnosed, 24 million working days lost. Those are 800 million direct healthcare costs, double cost of asthma, 10% of all hospital admissions. Now, this is an important statistic. 30% of all COPD admissions are readmitted within 3 months. And that has been difficult to tackle. We've got community program. We still see people coming back. 10% of COPD patients die within 3 months of being admitted. And as I said, in UK, around 30%. And comorbidity is very important. 70% of patients have mild to moderate disease at diagnosis, and patients are often symptomatic for 5 years before prior to diagnosis. So this is a map of COPD emergency admissions. It's a little bit older, but I don't think this has changed at all. And we see pockets in London where we expect northeast, Liverpool, Manchester area is exactly where you expect. It's the lower socioeconomic and also in the industrialized areas. I have to say something about pink puffers and blue bloaters, that somebody would ask me about it. Where have they gone? Well, we still see some, but much less. So the pink puffer was classically the patient who was mainly emphysematous. My own view is that these were the very severe patients who had smoked very heavily. The blue bloater was different. Again, a number of these patients have sleep apnea, they are obese, they're more likely to have hypertension. I'm afraid COPD is changing. We're seeing less of these polarized phenotypes. We're seeing really a combination. I think we're much better at diagnosing off sleep apnea than we used to be. So how do we diagnose this condition? We do it by symptoms, chronic cough sputum, winter bronchitis is key. Risk factors, tobacco, again, Some people have susceptibility. I think the more you smoke, the more likely you are to have COPD. Women are more susceptible than men. They have smaller lungs. Occupation, again, welders, burners, people who used to work, coal miners, industrious exposure, and indoor. We've already talked about pollution, and you need spirometry. This is a condition where we use spirometry for the diagnosis, but we don't necessarily base ongoing treatment on spirometry because the airflow obstruction is relatively fixed. So a few things. Dyspnea progressive over time, characteristically worse with exercise. You can have a chronic cough. Chronic sputum production, as I said, occurs in 50% of patients. This is important. They're the ones that are more likely to get exacerbations, and I think these are that, and particularly family history of COPD. We have one genetic disorder, which is alpha-1 antitrypsin deficiency, and I still think we test in our cohort everybody for it, but it is pretty rare. Okay, I just thought I'd show you this. Hyperinflation is key, and bronchodilators are the hallmark of treatment. We've got good bronchodilators at the moment. We've got long-acting, we've got combinations of long-acting beta agonists, antimuscarinics. So this was an image, in fact, that was sent from a so this is a transplanted lung on this side, and this is the diseased right lung, and you can see inspiration. And when you expire, what's supposed to happen is that the lung deflates, so the good lung deflates, but the diseased lung, in fact, still remains inflated. So this is what you actually see in COPD, and which, in fact, gives you the dyspnea. Dyspnea is very important, and as I said, anyone with significant dyspnea should be placed on, I think, both a long-acting beta agonist and a long-acting antimuscarinic singly or in combination, whatever you like using. And this is key because exercise is very, very important. And this is my work. Again, few people say it's not quite right, but I'll tell you why it's not quite right at the moment. This was done in almost 50 years ago now, and we had two groups of people. These had moderate dyspnea. These were housebound patients. And these were very severe patients. They were on oxygen, they were on ventilators, and we did the standard 8-week pulmonary rehabilitation program of 3 times a week exercise and education. We couldn't do anything with them. It was the patients, this is placebo, this is exercise, it's the patients who still had some capacity to exercise, so this is MRC dyspnea 3 and 4, they were still limited. They're the ones where we saw an improvement in walking distance. So the message is get people with COPD to exercise early. It is very, very important. Once they get to very severe disease, it's very difficult. Now, I think this data is right. I think we all know we've all got housebound patients who do very little at home. The other thing, you have to maintain it. We did do a maintenance program, probably not enough. They do drop off. And I think patients probably need to keep the exercise going with probably at least monthly supervision. That is a lot of ask for an overburdened health service, but this is absolutely key. It's one of the interventions that gives you the best improvement in walking distance. Okay, so this is my topic, COPD exacerbations. This is what we've studied for years. The major cause of COPD exacerbations are viruses, and up to now, rhinovirus was the cause of around half of all, or 2/3 of all COPD exacerbations. The other were, of course, influenza, parainfluenza, coronaviruses were there, 229 and 43 were the 2 viruses that used to be around that caused it. And in fact, we always believed that bacteria were secondary invaders. Bacteria, of course, also colonize the airways. So you've got viruses, you have an inflamed airway, more airway inflammation, and that causes increased sputum production, increase of dynamic hyperinflation, I showed you, increased shortness of breath, and it leads to exacerbation symptoms. And at the same time, there is systemic inflammation and cardiovascular comorbidity. So patients who come in with a COPD exacerbation are at increased risk of cardiac comorbidity. So this shows you an exacerbation. One of the very first papers we wrote on this, symptoms go up, but they take a long time to get back to normal. This is the reason that we see readmissions, because exacerbations, some get better quickly. I'd be very interested how coronavirus resolves, and I bet you it has a long tail of resolution, and then you get another infection on top. Well, maybe one of the reasons people get so ill. But it's this non-resolution of exacerbations that we subsequently, a few years ago, did some work to show accounted for the decline in lung function. So this was the paper we showed, and we showed, contrary to what Fletcher and Peter wrote, that daily cough and sputum was very important, and the number of exacerbations in the previous year. Pretty obvious stuff, but it wasn't obvious at the time. So patients who get exacerbations will do it again. Patients who have bronchitis will do it again. And the person who did a lot of the work with me, Terry Seaman, who's now Dean and Head of the Medical, Dental, Everything University in West Indies. He was a super guy. He was actually a statistician who became a doctor. And this is how we did all these absolutely beautiful curves, because he knew how to do them. And this shows you how common exacerbations are. So if you've got severe disease, 2/3 of people will exacerbate every year. And of course, these are the people most at risk of death. 1/3 of these people have a hospital admission at least per year. If you've got moderate disease, even 7% of patients get admitted to hospital. There's a higher chance of pneumonia in patients with COPD, probably due to inhaled steroids. And you can see how that goes up. 22% of patients already in this moderate had 2 or more exacerbations in the previous year, treated with steroids and antibiotics. So this is common. A lot of these exacerbations are treated at home, but you can see the increased hospitalization rate. And this was our work. We showed that frequent exacerbators decline their lung function more than so infrequent exacerbators, and the difference was 25%. So 1/4 of the disease progression we put down to the effect of exacerbations. And exacerbations do more things to revolving circle. You get more infections, you have more depression, more psychological problems, more comorbidity, increased cardiovascular risk. So these events are key to a lot of problems. This is one of my favourite papers, and I'm sorry there's so many dots, but you may think, gosh, how do they draw a line? That's about right. What this shows is that the earlier you treat somebody, delay between onset and treatment, the greater the symptom recovery, the better the symptom recovery time. So the earlier you jump in, the better you do. If you wait before you treat a COPD exacerbation, you will have a longer one, and it was these people who ended up in hospital. And we now know there's a lot of community programs that have been developed. You know, I would take a little bit of credit for this, because we pointed out how that you need to get at these people very quickly. The earlier you treat these people, the less likely you are to end up in hospital. This is data that we did now looking at the general practice database. So these are exacerbations 0, 1, 2, 3, 4, 5. Risk of myocardial infarction. If you are a very frequent exacerbator, your risk of myocardial infarction and of cardiac comorbidity is high. The signal is there. It does not mean that everybody who has an exacerbation has a heart attack, but patients who come into hospital, it is worth measuring their troponin levels, because they're the people who are at risk. This was work we did on aortic pulse wave velocity. So this is stable exacerbation. If you have infection, your aortic pulse wave velocity increased. Aortic pulse wave velocity, just to remind you, is a measure of cardiac risk. Patients with COPD tend to have heightened pulse wave velocity. If you didn't get an infection, the effect on the exacerbation was less. And this could partly explain the heightened risk. So how are we going to treat these exacerbations? Well, as I said to you, this is a disease that's been around. This is 1878. This is a fantastic book, and those of you who know me will know probably the history of this book is that I was clearing up my things in 2005. I was leaving the London Chest Hospital to go to UCL, and I found this behind the cabinet. I found this book lying there, and it was full. It's got the most fantastic description of COPD and of bronchitis, and it tells you what to do. Catching cold is a far more important cause of bronchitis than pneumonia. That's fascinating that they linked colds to the airway disease, 130 years ago. Next to avoiding a fatal issue, our efforts must be directed to prevent the case going on to chronic bronchitis, especially in those who have had previous attacks. So they told us that if you have a previous attack, you're at risk. And for those who can afford it, a seasonable change to one of the Mediterranean health resorts or to Rome and Egypt is highly to be recommended. I wouldn't go now to Tenerife, but that was a very good idea, because of course viruses are more prevalent in cold weather, and that is why everybody's rather hoping that corona will go away in the next few months. That's if it likes the cold weather. I'm not sure about that. So what do? We give steroids to people. Again, this is very little data that steroids help, but that's what we do to people. And why do steroids help? They probably reduce mucus production, they reduce some of the inflammation. This shows lung function in a steroid-treated group or a placebo group. What about antibiotics? Well, if you go in and read up, they'll say, that antibiotics help, they don't help, they're ambivalent. Absolute rubbish. What antibiotics should be used at exacerbations if there is purulent sputum. Purulent sputum is a marker of infection. This is why. So, when you have a virus, this is the virus, this is human rhinovirus, this is the exacerbation. Over the next 5 weeks, the viral load reduces. The bacteria come up later. We believe that the bacteria are secondary invaders. As the virus damages the epithelium, bacterial load increases to the peak. So these were people who had no bacteria at the start. These are people who had bacteria to the start. Everyone was given steroids and antibiotics. The bacteria fell and then came up again. And again, we believe this is why bacterial infection is very, very common, particularly if you've got more severe disease. So if you've got purulent sputum, you've got severe COPD, you do need to give the people antibiotics. Very, very important. This was one of the arguments was what to do in mild patients, and this was a very good study from Spain using Carmoxiclav, and they showed very nicely that this is people who are exacerbation free after that they did much better than patients who were on placebo. So the evidence is there. There's a group in Belgium who keep writing papers round journals to say that antibiotics do not benefit patients with COPD. They really should be shocked, and that is not right. What about our strategies to prevent exacerbations? As I said, bronchodilators are key. They're the cornerstone of treatment. Inhaled steroids. In fact, recently the evidence is that if your blood eosinophils are high, again, how high, and I'll talk about that afterwards, then you're more likely to benefit from inhaled steroids. And combination, we have now triple inhalers, which are LABA/LAMA, and an inhaled steroids. As I said, we have dual bronchodilators. I'm going to say something about macrolides, other antibiotics, and we also in the UK have roflumilast. Don't forget about non-pharmacological, really important: pollution, smoking, pulmonary rehabilitation, vaccination, non-invasive ventilation has also been shown to prevent exacerbation when used long term. So again, I'm going to show you a few studies. This was in fact a study that GSK sponsored, which was a LAMA against a LABA-ICS. Nobody thought they'd be equivalent, but they are. So this really changed our thinking that we don't need to give inhaled steroids to everybody like we do in asthma, that we start off with bronchodilators and use inhaled steroids if patients are still exacerbating. Inhaled steroids don't do anything in COPD except prevent exacerbations. So if you're not an exacerbator, you don't need to use it. This was the paper of mine in New England. where we took patients who were of moderate risk, and indocapsular glycopyrrole is a dual bronchodilator, it's ultibro, Novartis is ultibro, and we actually showed that you were better on that than with salmeterol, fluticasone. Your chance time to the next event, 60% risk reduction for all exacerbations, 22% risk reduction, which is pretty good in COPD. So you then would add the inhaled steroids once patients get into the higher risk categories. This is in fact triple therapy. This was published 2 years ago and 18 months ago, and this showed that if you use triple therapy, these were very severe patients. A quarter of them had been in hospital in the previous year. Most of them had had 2 or more exacerbations in the previous year, and these patients did better on the triple inhaler. There's been a lot of argument about this upstroke here as to whether there were withdrawal effects, but I'm not going to bother this technical issue on the Sunday morning. You can give a whole lecture about people are giving. I sat through a whole lecture the other day on somebody just talking about the upstroke. But basically, as risk increases, you increase the treatment. What about roflumilast? Interesting, and one that I have actually studied quite a bit, phosphodiesterase E4 inhibitor. It's an oral drug. It was shown to work in more severe patients who had bronchitis. When they added it to patients with, you can see that the roflumilast looks better. It wasn't as good as you would expect, but all along, I haven't got another slide. All along, the studies that have come out is that if you're a very frequent exacerbator, it's worth a try. One problem, it makes people feel sick. So we did a study acutely with it, because we got so few acute treatments and half of our patients felt sick. We were very, very surprised with it. So if a patient can tolerate it and they're bronchitic, it's a good go. Well, what about long-acting antibiotics? And those of you who are older than me and will probably remember that we used to use rotating antibiotics. This is Haemophilus moritella, strep pneumoniae. This is what's found in the airways. If you have more bacteria, you have more bronchitis and more COPD. And we're now going back to 1960. And a study was done with penicillin, tetracycline was compared against control. There's not a lot of stats in it, but they did do some. They did some nice outcomes, days off work, duration of attack. They actually did exacerbation recovery and showed if you were on long-term penicillin or tetracycline, you actually did better. And this is really what led to rotating antibiotics, and they did some cost. And really people forgot about this till macrolides came along, and this is one of them, azithromycin. It's the one I would use, 250 milligrams 3 times a week. Macrolides get concentrated in the lung. You don't need to use them very often. They do all sorts of things. They're antibiotics, they affect neutrophil activation, they are anti-chemokine, and they have a number of immunomodulatory functions. They're very interesting, and really they were used in cystic fibrosis. Patients benefited from them. So they've also been used in COPD. This is our study. We actually did erythromycin because Pfizer, who used to own azithromycin when it was still on patent, wouldn't give it to us. They promised it to the Americans. But we showed that patients on a year of erythromycin did better. Again, this was 500 milligrams a day. And we had some GI effects, but relatively few at that low dosage. And the only thing to be careful is cardiac effects that macrolides can prolong QT intervals. And the other thing is that in the American study, they gave it daily, 250 milligrams azithro daily, too much, and patients had hearing problems, which were reversible. So 250 milligrams 3 times a week. If you want to use it, it is really the time for specialist referral, because I think the patient needs CT scanning and a few other things. What about other long-term antibiotics? Well, basically you get resistance. So this was part of my program grant. We compared azithromycin, moxifloxacin, and doxycycline. It's a long story why we compared these 3. But it was to do with what government wanted and what we wanted to a certain extent. And you can see resistance. This was only 6 weeks, 3 months, sorry. Everyone increases resistance. So you get resistance even if you use antibiotics for 3 months. You'll be interested to know that we gave a year of doxycycline to patients. It made no difference whatsoever to exacerbation frequency. It was a relatively small study, but it doesn't look as there's anything there. So if you're going to use antibiotics, it really should be a macrolide and nothing else. Shall we talk about that? What about other targets? Well, we're desperate. Certainly anti-IL-5 has been tried, mepolizumab, benralizumab, both have been tried in COPD, and studies have been completely negative. In the GSK study of mepolizumab, there is a suggestion that if you've got high eosinophil counts, you get a response. Surprise, surprise, those patients probably have asthma. Markers, MPO inhibitors have been tried, didn't really do anything. The problem is, this is a complicated disease. You've got remodeling, you've got bronchitis, you've got infections, you've got a lot of things going on, and you change one and you alter something else. So we are desperate for new targets. My last few slides is just to what should we do in the future. So we've now redrawn Fletcher-Peter, and we think it's like this, that some people start low and continue low. There are some people who start normally, they smoke, the red line, and they fall off. If you smoke here as well, you do very badly. So COPD, now at this point, we don't know if a patient is 70, did they have small lungs all the time, or were they somebody here who had a big susceptibility to disease? We feel if you've got small lungs, there's probably not much you can do about it. If you're one of these people who at 30 starts declining, and this is the onset of COPD, you probably can intervene early. So it's very difficult when Sarah and I see people in clinic to sort out how long they've had the disease. Certainly, the more you smoke, the more likely you are to have a steeper curve. So this is very interesting. This is the 1946 birth cohort. So this was everybody who was born from March the 1st to March the 8th in the UK in 1946. And it's about 6,000 or 7,000 people were put into obviously they had to agree to do it. So 4 years ago, they celebrated their 70th birthday. Unfortunately, I couldn't go to the party, which was actually held in Senate House. But you see this photo, and what hits you is that all these people, except these are the people who started off the whole program. He came, I recently went to a lecture telling how they did it. They all look different age. Some look aged, some look really young, some look old. All these people are actually age 70, but they are all very different. And that is the problem with aging. And COPD is affected strongly by aging. Well, we were very lucky to be able to study data. I was approached, in fact, by Steve Colgate from the Medical Research Council as to whether this cohort could help in lung disease. And I was told by everybody, it's not enough people. If you've got 5,000, 3,000 living, you can't do anything with it. Everyone needs 100,000. But we thought we'd have a look at the data. And this is what we found. Now, I'll take you through this. This is the ages. This is the ages they were assessed: 20, 25, 36, 43, 53. The first thing we noticed, if you were a persistent smoker, this is the prevalence of bronchitis, chronic mucositis secretion. You took off between the ages of 36 and 43, typical in British 1946, 1950 style. There's really good data about bronchitis in this cohort. And if you continue to smoke, your chance of bronchitis continues. If you quit, you can see the bronchitis reduces. If you've never smoked, you slightly increase. So this is the point that we decided you needed to target. And these are the odds ratios shown between 36 and 43. These are the people who ended up with chronic airflow limitation. This is almost my last slide. This is the number of occasions, men on the left, women on the right, that they actually reported bronchitis in everything. And you can see that 0, 1, 2, 3. So if you reported bronchitis 3 times earlier on, you had a fall off in your lung function, and even more so for women because they've got smaller lungs. So we've now moved on into different things. We set up, with the help really of Imperial, we approached the Medical Research Council. They wouldn't fund it. They said, you'll never find the patients. Because we're after smokers, 10-pack years, age 30 to 45. British Lung Foundation, early COPD cohort, 1,000 patients are being recruited in the UK in 8 UK academic centres. Industry, we persuaded 5 big pharma to each give $1 million towards this, and everybody signed the same contract that Imperial actually wrote. It was actually a miracle. I spent a year sorting this out. But we're now going, University of Iowa, they just happen to be very good. There's lovely pictures I showed you of the small airways disease and emphysema that come from Iowa. They're doing all our CT scanning, or spirometers in the US cohort that are actually following us now. And we have a branch, because Imperial College has a branch in Singapore. So what we've recruited now around 700 of the 1,000 patients. We stopped recruiting at the end of this year. We should make the target of 1,000. And these people are going to be followed in the long term to see what's going on. We haven't a clue what's in the airways of these smokers, aged 30 to 45, and which patients get into trouble. Because it seems that if we intervene later, we do very badly indeed. And again, going back to the global issues, how many smokers, biomass are there? Younger people, they're all getting ill early on. And I think by understanding what's happening, we can find the best interventions. Thank you very much indeed.
Professor Wedzicha, thank you very, very much for this fascinating lecture. I'm sure we all learned a lot. And I open for discussion. I'm sure.
Can you just tell us about the prevalence of smoking now? Is it going down?
Yeah. So it did reach, before 2004, before we had migration, it was around 21 to 22% in the UK. Then went up to 23, 24%. Now, of course, we've got vaping. I haven't talked about vaping.
I was going to ask you about that.
Yeah, I am afraid I think vaping is just as bad. I completely disagree with using vaping to stop smoking. The American data, which I am privy because I edit their journal, is that inhaled nicotine causes quite substantial airway damage. I think there's 2 components. There's the tar, but of course the cigarette companies have got rid of a lot of the tar for years. They filtered cigarettes. So actually, they've been given mainly nicotine to people. To be honest, I meant to mention vaping, and I didn't. So I think the figures are that about 1/3 of smokers are currently vaping, but I put them all in the same category. As you know, the worry is that kids are vaping, that people are vaping very, very, very early on. And in our early cohort, 20% of people have started vaping. So what we're doing, we're going to follow them long term. So we're actually going to have a smoking change to vaping study, but it means we've had to recruit a few more patients to do the vapors, to see what's happening. So please, I really don't think we should encourage vaping. I think there may be a few people who it may help to stop, but it should not be a universal recommendation. Yes.
Given the influence of pollution on lung disease, is there any evidence for effectiveness of the household filters, the HEPA filters that are on the market?
Do you know, even if you go to Malawi, what I didn't show you was effects data on biomass. It's just incredibly difficult. There's arguments both ways that biomass doesn't do as much as you say, others say. It's really difficult to show. And there is no data that I know about that in fact shows that filters. We once did a study where we went into people's homes and took pollution monitors and measured against exacerbation, we didn't see very much. I think, you know, if you do this work, you probably need to do it on a really, really large scale. Yeah, I think in the UK, pretty good actually. You know, there's obviously Oxford Street's not wonderful, and the Oxford Street asthma study showed that people got into trouble, but I think apart from areas of very heavy traffic, it's not actually that bad, except when you get a smog episode. It's abroad. I notice it when I go to Hong Kong. Singapore's all right, but I certainly notice the pollution in Hong Kong when I'm there, especially if you go at this time of year. Actually, I'm not going at this time of year, don't worry. Yes. Yes, yes.
Yes, during the war, actually, the cigarette was given to the soldiers.
Yes.
And obviously, they follow up later on. Related to cigarette without any addition to that, it was designed about 5 years ago and was suppressed by tobacco company in America.
Yeah.
And related to pollutions, I was doing some study in a university near Elephant Castle. And that roundabout that is created, we was chatting about
That's
lecture.
terrible.
It was so terrible, I cannot stand any longer. After about 5 minutes, I have to move because the concentration on that particular area was diabolical.
I think there are hotspots and I think that's a really good one. That roundabout. They have changed the traffic there now, as you know. It seems to be going in the opposite direction. I used to live around there. Actually, I used to live in Camberwell, so I agree with you. Though we don't see pollution levels in this country that you, for instance, see in parts of Asia. It is on a different scale, and we mainly get in London. We mainly get traffic pollution in London, which certainly can trigger up asthma. How much it triggers up COPD, we have spent a lot of my time. I could give you a lecture on this. It's probably, I think there are other factors that tickle up COPD more than pollution does, but it is a cofactor.
I've got actually communication with the Transport for London related to reducing the pollution level, and your data probably we'll chat about later on. It will be actually more to the point, which can study in various aspects of one roundabout is ridiculous as well. It's near Battersea Bridge.
Around there, okay.
There are about 36 traffic lights.
Yes. So we think in COPD that when you get a virus infection, you become more susceptible to the effects of pollution. Now, COPD, remember, is a pretty stable disease. There's a bit of variation. Asthma is completely different. It's a much more reactive disease, and it's much easier to trigger it. And you can show relationships between Oxford Street pollution and, you all remember the paper in the Lancet, a very, very nice paper that came out to show the effects on asthma. Just in COPD, it's just difficult. And we spent 20 years collecting data trying to show effects, and we could only show effects at the time of infections. Yes? Go on.
As an international expert in the field, could you update us about coronavirus?
Well,
what is your opinion?
What's my opinion? Please do not
Nice
vote on the web. My opinion is that the disease must be around, and I'll tell you why. Because on January the 28th, a paper arrives in the New England Journal of Medicine. I am an editor. I know even the New England needs 2 to 3 weeks to produce a paper and to put it, to check it and to do all the checks. So they must have had the disease from November onwards. You don't just produce a paper. Well, those of you they were busy looking after these people in Wuhan. There were 3 flights a week coming from Wuhan direct. This disease must be around. And it does look as if it is a mild disease that, like, rhinovirus, if you're elderly and get a cold, it can be lethal, can't it? So it's most people come in with pneumonia, so you can get rhinovirus pneumonia as well. So in most people, it looks as if it's a mild condition, My bet is that the virus should weaken, because it's not a human virus. It is it is an animal. It's a bat virus. It should weaken. SARS just disappeared very conveniently. To be honest, Hong Kong got on top of SARS, and then it disappears. But it was a very similar coronavirus. So molecularly, that's why they got the testing kits so quickly, because they were very similar. How prevalent is it? Well, I was talking to Sarah and her husband just before, and Sarah knows I've spent 20 years measuring viruses in people's airways. And it's not easy from a nose swab. We've just done a survey of RSV, respiratory syncytial virus, and we only found 2 viruses in the nose swabs, but we found 30 in sputum. So swabs are not perfect for the virus. And that's my, I think if you really want to find it, you've got to look for it in sputum, in nose, everywhere, if you really want to get a good feel. So, for instance, this case in Hazelmere, somebody felt unwell, got tested, they could have thought they had straightforward flu, couldn't they? So my hunch is that it's around, it's been around. I think we should do everything to stop transmission, like yesterday in church, I absolutely refused to give my hand to anybody. What on earth? I've actually emailed the priest today to say, Sean Sulex got an email from me this morning. I was horrified. Everyone around, they always, and my mother was doing this, don't touch me, Mum's 98. I'm not joking. We were saying, no, virus. My cousin was sitting at the back, it was hysterical. And I was saying, oh my God, we shouldn't be doing this. People just need to be a bit sensible, I think, to avoid transmission. What the government's saying, wash your hands, just avoid more contact than you need to, isn't it? Yeah. Sarah, what do you think? What
exactly the same. I think we need to all be hand washing, using gel, embracing each other regularly,
no
and
kissing,
not shaking hands,
no
and
social kissing.
Tissue bin them. So it's common sense actually, and I agree with you. I think it's been around.
I think it's in Hong Kong, nobody shakes hands in church, by the way.
Well, they haven't got time to. Time is money. It's in Hong Kong.
Sarah, I think it's been around. I'd be surprised if it hasn't.
I completely agree, and also I think it's affecting the elderly more. So the elderly and frail. So people need to be mindful of that and not go to busy places where people might cough and sneeze.
So I thought I would go to see Jonas Kaufmann is singing in Fidelia. I've got tickets on Friday, but I've decided not to take my mother, which is a great shame. In fact, I even managed Covent Garden. I rang them ages ago before I knew if we could have some really accessible seating. So where in Covent Garden's easy, you go in and it's almost the stall circle, there's no steps, but I've decided not to take her.
The concern really is more about the economy. That's more the concern, the effect it will have on what we do and our behaviours.
Exactly, but I think it's probably around. I think, 7,000 people have been tested, but, Sarah and I have a colleague called Sebastian Johnson who knows a lot about virus infections, who taught me how to swab people and look for viruses. And he said just because the virus, you don't pick it up doesn't mean it's not there. Swabs are you all know, are very hit on. Easy to get bacteria out of swabs than it is viruses out of swabs. And again, I asked Sarah the question, how sensitive is the PCR testing equipment? I meant, we have somebody, said, well, no. I don't know. Coronavirus is very difficult to measure anyway, let alone, we could never do it before the current testing. So I think we've got to be sensible, and just try and, I'm being very, very careful at home where I'm taking Mother. And I even thought I might not take her to church next week, because people keep their paws off her, just.
But then if you go, then when you get it,
I know. There's nothing I can do about it, isn't it? But she's more susceptible. So there's a paper, I edit the American Journal of Respiratory Critical Care Medicine. We've had an interesting paper that we're not going to publish for various reasons, but they show that the first person in the family gets it the worst. And then as they went down through the kids, through the families, number 2 got it less. That's what you expect. You expect this virus to peter out a little bit. But why there's suddenly an outbreak in North Italy, did people just go around testing? I don't quite understand these outbreaks, that's the worry.
But presumably the people in northern Italy, they're not all being hospitalised, are they?
No, well, they've had some deaths, but again, you know, people die from COPD. There's a 1 to 2% mortality in COPD. If you get pneumonia, it's really just, there's an exponential rise at the moment in cases. If you look at the John Hopkins, if anyone's interested, John Hopkins do a website and they show you where they are. China's doing this, it's petering out in China,
Yeah.
and Wuhan, but we're going up at the moment. I think it may be just because everyone's testing, you know, they're testing people.
We haven't any in Poland.
Is that right?
They have
Well,
I heard
It's not.